The accepted criteria for a high probability pulmonary embolic phenomena with a more than 80% probability is the presence of two or more large mismatched segmental defects without a radiographic abnormality, or the perfusion defect is substantially larger than the radiographic abnormality. And then any combination of mismatched defects equivalent to the above. And remember that 2 moderate equals 1 large. This is an example of a high probability lung scan in acute pulmonary thromboembolism. To your left is a technetium DTPA ventilation scan. To the right is a technetium perfusion scan. Note the multiple defects on the perfusion scan and areas of normal ventilation, the so-called positive Robin test. This middle-aged patient had tachypnea and a normal frontal chest rentgen. The lateral chest rentgenogram was. The top row reveal a perfusion scan. Note that the lower half of the left lung shows no perfusion. And we can see in the ventilatory scan, which is in the bottom row, that the ventilation was normal and preserved. This is another example of the limitation of chest radiography and the information that we can obtain from a perfusion ventilatory scan, and this patient shows the positive Robin. These are perfusion scans on your left and ventilatory scan on your right. The dorsal images showing a perfusion defect in the left base with normal ventilation at that. This is to show the merits of repeated scans to assess the resolution of areas of embolic occlusion of the pulmonary arteries. We can see here on the perfusion scan above and the ventilatory scan below that there are unmatched defects. Positive perfusion scan, negative ventilatory scan in a proven case of pulmonary thromboembolism. 6 days later, repeat perfusion ventilatory scan shows still some defects in the periphery of the lungs, but almost complete resolution of the oligemic areas. The ventilatory scan remained normal.